Thank you very much, Yanis. I'm honored to be part of your National Congress. I come from Milan, Italy. And in Milan, we have, I direct there the specialty in PRM. And in the country, we have 27 PRM schools. And you can see in brackets the number of residents for each university. As you can see, Milan Statale is one of the 3 University of Milan, has the highest number of residents. And in total, the number of residents has increased during the years. We are now 372 residents in Italy. So we are, that meaning we are a large society. And University of Milan is ranking number one in residence positions nationwide. It has the largest academic faculty, 1 full professor, 4 associate, probably 5 next year, 2 researchers, and a big network that operates with the school. The school functions as a central hub and is connected with several facilities serving at practicing points. Just to give you a glimpse of the extensive network of hospitals, we have spinal cord units, we have pediatric rehabilitation, geriatric rehabilitation, we have advanced neuro rehabilitation with robotics. So it's quite a large network of facilities. And we have a rotations of the residents. They stay 6 months in the rehabilitation unit, and they rotate for 3 months in what we call the main branches, the internal medicine, neurology, orthopedics, emergency medicine. We have an extensive programs of lesson. You can have a picture here. And I'm going to introduce next year some aspects, nutritional aspects in rehabilitation, which I think is very important because that's probably a missing link for improving the rehabilitation outcomes. And we have organized the school with electronic training logbooks so that the residents have certified activities validated by tutors, and we can follow the progression. We try to involve all the residents in congresses, national, international, and in research activities. I think this is very important to have PRM who do research. We need that. My clinical work is at this institute, Auxologico, is an institute for care and research, meaning we do clinical care, but also research. And we have several hospitals. I worked many years in this beautiful location. It's a reference hospital for metabolic conditions, severe obesity, and all the spectrum, the range of eating disorders, including anorexia nervosa. And we have several hospitals in Milan, and you can see lately in the years also in Rome and in Romania, as Professor Bertiano knows very well. And the main research areas are in cardiovascular diseases, in auxoendocrine diseases, because we have also the congenital obesity, like Prader-Willi syndromes. We have a large activity in neuroscience and also in psychology. But coming to my topic, well, it is no news that obesity is pandemic. As you know, you can see that from the color blue on the maps. And you can see that in a few years' time, 20% of the world population will be obese, according to the meaning people with a body mass index over 30. And obesity rates are much higher in adults with disabilities. Think of conditions like spinal cord injuries or amputation, where we have a dramatic change in body composition. In fact, we have guidelines for reducing the cardiometabolic risk in a spinal cord injury patient. The rate of obesity in spinal cord injury patient is around 40%, so it's quite high. A body weight is a variable, is a dynamic variable, and is influenced by multiple factors. We have certainly a genetic predisposition, monogenic, polygenic, and then we have the factors from the environment, starting from the uterus. from breastfeeding, from puberty, and all the lifestyle we adopt, sedentarism, eating habits, and so on. The physiopathology is very complex. It involves many neurohormonal factors, but that goes beyond this talk because the reason why I'm talking of obesity at a PRM conference is that we, PRM specialists, have to face the disabling consequences of this condition, which is chronic, is relapsing, is progressive, and is associated with this range of conditions that you can see that can worsen and that can tip the balance of independence. So it can become disabling. Unlike hypertension or diabetes, obesity doesn't have a clinical parameter. BMI is not a clinical parameter, is something useful for epidemiological reason, but it doesn't tell anything about severity of obesity or body composition. So at the end of 2024, last year, this commission of the Lancet came out with this definition, which is clinical obesity, a condition in which the risk to health associated with adiposity has already materialized and can be documented by specific signs and symptoms reflecting the biological alteration of tissues and organs. And in fact, in obesity, there is a coexistence of disability. Disability is evident in the later stages of this is the Edmonton obesity stage, and this is the most widely used scale for the severity of obesity. And you see that stages 3 and 4, where we have severe medical and functional impairments, we have disability, and that requires a multidisciplinary rehabilitation approach. Whereas at lower stages, 0 and 1, we have a more chronic aspects of that. And there we can use a lifestyle intervention, change of diet, physical activity, and so on. We can, with intervention, we can lose weight. The problem is that losing weight by reducing calorie intake, we reduce energy expenditure, and that promotes weight gain again. So the maintenance of weight loss is very difficult, and people who work with that knows that very well, and patient knows that very well. But losing weight is crucial because the greater the weight loss, the greater the health improvements. If we reduce by 5% our body weight, we can reduce the risk of hypertension, hyperglycemia. But if we go up to 15%, we can have remission of diabetes and reduction of cardiovascular mortality. The most effective way to get those results is nowadays still bariatric surgery. We can achieve weight loss over 20%. But we live now in an era of anti-obesity medication, as you know. There are very effective drugs, semaglutide a few years ago, and now tirzepatide is very effective. It can reach the goals I showed you with a weight loss of at least 15%. But in this era, the problem is those drugs, they reduce weight loss, they reduce body weight, but they reduce muscle mass as well. It has been estimated that 25% of the weight loss is muscle mass. So you can understand that physical activity is still crucial in this pharmacological era, and is crucial for the maintenance of muscle mass, is crucial for the to avoid the progression of comorbidities for health reasons. So just to give you an idea, when we have an excess of body mass, we have an hypertrophic adipose tissue. This hypertrophic adipose tissue release an excess of pro-inflammatory cells, and those, by the way, are the prime movers for hypertension, type 2 diabetes, cancer, and so on. And this chronic inflammation status, in which those patients are living, interferes with the synthesis of protein in the muscle, with the proliferation of muscle fibers. So we have the so-called myosteatosis, the accumulation of lipids in the muscle. We have a reduced muscle function, reduced mass, reduced strength, reduced performance. So we have a vicious circle because that creates reduced physical activity, reduced energy expenditure in a vicious circle. And this excess of inflammation also interferes with the bone formation, bone resorption, also with the cartilage degradation. So it's clear that there is a link between what is happening metabolically and our locomotor capacity, a link between our mobility and our metabolic status. We know that posture, the excess of mass, shifts forward the center of mass. So there is this momentum on the lumbar spine with an increased risk of low back pain. And also we have this cranial displacement of the diaphragm caused by the presence of fat, of abdominal fat. And we have a closure of the small airways. We have an increased work of breathing of the patient, reduced ventilation perfusion ratio at the lung base, so the respiratory capacity is dramatically reduced. So there is a sum of regional fraities that sum up to give a picture of global frailty. Those patients can be really frail patients. The comorbid obesity can be really a frailty status that require multidisciplinary rehabilitation. What about the post-acute patient? Stroke doesn't seem to impact that much. Obesity doesn't seem to impact that much on stroke. There is the so-called obesity paradox. There is even a reduced mortality and hemorrhagic transformation after stroke in obese people. And you can reach the outcome not differently from lean subjects, so it doesn't impact that much. Whereas when an obese patient undergoes orthopedic surgery, there is an increased risk of infection pre, intra, and post-surgical. Therefore, there are longer hospital stay, but after this longer stay, you can reach the similar outcome. In Italy, the Ministry of Health acknowledged the need for a specific rehabilitation pathway for those people back in 2011. Later on, we had a position paper from the European Society, and in 2020, we published those guidelines jointly from the ESPRM, the European Society, and the International Society on the rehabilitation of adults with obesity and related comorbidities. And those guidelines say basically that the rehabilitation unit should be structurally adequate with bariatric lifts with a capacity of 200 up to 500 kilos to reduce the risk for nurses and physiotherapists and patients themselves. But they should also be organizationally adequate with the presence of dietitian, nutritionists, psychologists, psychiatrists in the team. We have to understand that I'm talking about a disabling condition, and a weight-centered approach, just reducing body weight is not enough, because that would exclude patients who are already in an advanced disease stage and where weight loss is unlikely to reduce disability. There are complex patients. We can assess them with the burden of diseases, of comorbidities with the, for instance, with the CIRS, the Cumulative Illness Rating Scale, or with the Rehabilitation Complexity Scale. We can prove that those patients are complex patients. And we develop also a specific disability scale specifically for those patients. They have an individual rehabilitation plan that has to encompass all those aspects. And we have to share goals with the patients, with the caregiver. Those goals you can see on the slide in the different areas that are realistic and that are measurables. The patients agrees on them. For instance, to monitor motor improvement, we can use the hand grip or the time up and go, or the 6-minute walking test for monitoring, assessing cardiorespiratory capacity. Physiotherapy doesn't differ much from that one we use for lean patients. For instance, in this study, we showed that if you let people exercise with motor control exercise of the lumbar pelvic, you also improve respiratory function for the abnormal posture I showed you before. But basically, the techniques are pretty the same. What I wanted to stress with you today is the contemporary vision of the prescription of physical activity. Physical activity is what we prescribe to have myogenic, chondrogenic, osteogenic effect. So we look for an anti-inflammatory effect, an effect that boosts immunity. Whereas if we don't prescribe exercise, we have all those catabolic effects you see on the slide. It is important to remind that the function of the muscle is not just a functional organ. It's not just for movement, balance, posture, and strength. It yields very important metabolic function. The muscle is a reservoir for amino acids, and amino acids, as you know, are important for many functions, immunity, for instance. And the muscles produces and releases molecules that are called myokines that interfere and regulate the homeostasis of practically all the organs, from the immune function to the brain, to the vascular system. So it's quite clear that when we have a poor muscle mass, we have poor health outcomes because our immunity is reduced, our brain function is reduced. And we know now a lot more than we knew in 20 years ago, because we know how exercise works at molecular level. We know that many organs, in the year 2000, they discovered that interleukin-6 was produced by the muscle, responded to exercise, and was acting as a molecule that produced muscle health. And we know now that there are a range of organs releasing those exerkines, as we call them. So we know now names of those exerkines that have a cardioprotective function in improving the endothelial function, reducing blood pressure, and so on. We know those who boost the immune system because exercise in the long term has anti-inflammatory effect. And we know that certain exerkines cross the blood-brain barrier, go to the brain, and affect the activity, especially of the hippocampus, where the famous BDNF, the brain-derived neurotrophic factor, is produced. And that boosts neurogenesis, cognition, and so on. So there is a muscle-brain crosstalk, and exercise can beneficially affect neurogenesis, learning, memory, mood, and so on. We know that not necessarily high-intensity exercise, but also gentle exercise, like Tai Chi, for instance, it improves functional brain network connectivity. We know that from functional MRI. The gentle exercise can improve the circulation of neurotrophic factor that increase the connectivity of the brain. And so the goals of physical activity, as this society, the European Society for the Studies of Obesity reminds us, have a health goal, is to improve cardiometabolic health, to improve body composition, quality of life, and so on. Which exercise? The mostly prescribed is the moderate intensity continuous exercise. And most time efficient exercise is HIIT, high intensity interval training, which can be difficult on land for those subjects. It's a bit easier on underwater, but this very recent review says that there are modest superior effect of HIIT as compared to continuous training. Modest effect on the VO2 max and on glycemic control. We all know the recommendation for physical activity to do moderate intensity every week, 150 minutes to 300 minutes per week, and 2 days of muscle strengthening. But the problem is that not many people care about that. And probably there has been in the literature and also in the mediatic messaging, there is been an emphasis on aerobic activity as compared to resistant training, despite the fact that we know that resistant training has all these health benefits, as these seminal papers back in 2012 pointed out. But who is meeting the muscle strengthening activities guideline? Very few people. Those reviews tells us that a small share of people do resistant training, less than 20% of the population. They all agree on those numbers. So bearing in mind this, the WHO issued in 2020 the new guidelines for physical activity and decided to start from scratch. They decided that, first of all, we have to target sedentarism and to replace sedentarism with any activity you can do. So every move counts. And then you escalate to further and higher prescription. Oh, sorry. Prescription. And in fact, we know from physiology that the sedentary people are the one who benefits most from even little changes in physical activity. If you look at this benefit and physical activity dose diagram, sedentary people in A, they have the most benefits, even for small changes. And in fact, the paradigm is this one, is not much our prescription of moderate to vigorous physical activity that affects health. Health is affected by the interaction of all those activities. How much we sleep, how much we sit, what we do during our daily routine. So the light physical activity, that what affects health. And this cardiological review showed this matrix where you can see the deleterious synergy of the hours you spend sitting and the minutes of physical activity. The highest risk of cardiovascular risk is, of course, for less than 5 minutes physical activity and more than 8 hours spent sitting. But that tells us that you can, there is an opportunity to reduce the risk by even slightly increasing physical activity and reducing sitting. So there are some good news there. And in fact, the more recent literature looks at the minimum dose of physical activity which has a health effect. This, for instance, was a study on Lancet Public Health that estimated that approximately 5 kilometers a day, 7,000 steps, was enough to reduce the risk in many of the, you see, cancer mortality, falls. I can't read very well, I hope you do. But this is a lower dose than mediatic communication tell people. They were talking about 10,000 steps per day. So 5K should be okay. And also for resistance training, there are several approaches. For instance, for people with severe obesity, a good idea seems to have resistant exercise snacks. That means bouts of activity of very short duration, so very short volume that is performed several times a day. For instance, this Stamakis a few years ago talked about vigorous intermittent lifestyle physical activity. Bouts, very brief, less than 5 minutes, of intense, more than 6 METs or more than 15 on a Borg rating scale, of vigorous intensity activity embedded in the daily routine. So, which is feasible for most people. It doesn't require planning, contrary to more vigorous exercise, which implies that I have to plan it and I have to eventually being supervised or attend a class. So that seems a good idea. And the idea is to reduce the number of exercise and set per muscle group, to reduce the duration, to reduce the load, and to not use equipment. So to make it very simple. But the frequency is high because we do it 3 times, 4 times, 5 times a day. So the idea is recent. We are beginning to collect some evidence that with systematic reviews, meta-analysis, that start to support the effectiveness of incorporating those exercise snacks into daily routine, and they can enhance cardiometabolic health and enhance the metabolic profile as by decreasing cholesterol, LDL, and so on. So there is some initial evidence. For instance, 3 stair climbing exercise snacks a day with a 4-hour interval resulted for 6 weeks, resulted in an increase, in a 12% increase of VO2 max, and also an increase of the power of the muscle. So there is also an adaptation of the muscle to that form of exercise. Or just simply breaking up 9 hours of prolonged sitting with hourly brief stair climbing can lower postprandial insulin. And this study, they're all small studies because the evidence is not there yet. But those 2 bouts a day of 5 1-minute exercises, like sit to stand, seated knee extension of alternating legs, standing knee bends, and so on. They improved function, sit to stand, and they also improved slightly, but they improved the muscle mass as measured by the cross-sectional area in the DEXA. So it seems to be that exercise snacks can, first of all, interrupt sitting behavior and have the consequent metabolic benefits. And they probably, because they are more frequent, they can have a neural adaptation to improve the function, to improve strength and power. We don't know, don't have much studies about muscle mass. Anyway, as I told you, it's a recent thing, so the mechanistic basis of this exercise has still to be proved. Another important, and I'm going to finish. Okay. Okay. Is the synergy with nutrition. The synergy with nutrition is important because if you take in protein, especially essential amino acids, especially leucine, they will act on the same hub that is affected by exercise. So they will boost the synthesis of protein. And this is important for sarcopenic obesity. Sarcopenia is frequently encountered. And I just finish with this because we have developed, to boost physical activity, we have developed this digital therapy. Digital therapy is better than apps because digital therapy is something that has undergone randomized controlled trials, exactly like drugs. Is validated. Thank you and sorry for being long.